Good morning, Kin 28 years. This is Dr. Cosby. I'm going to go ahead and do an online lecture, which is essentially going to be a continuance of sports injury concepts and medical terminology. This is the part that we didn't finish in class. So we're going to start off with talking about grading injury severity. And what I mean by this is your ability to actually look at a ligamentous injury or look at a muscular strain and determine what grade of injury it actually is. What we know about injuries to the tendon, muscle, and ligament is that a lower grade injury, like a grade 1 injury versus a grade 3 injury, have implications for our patients. Grade 1 injuries aren't as severe, most often lead to earlier return to play, right? Whereas your grade 3s typically are associated with some type of rupture or avulsion, and so lead to longer return to play times. And so we're going to talk about those from a ligamentous and then also from a muscular perspective. So first and foremost, we'll talk about different grading schemes when it comes to the actual ligament itself. One thing that we'll do is during this lecture, we'll use the ankle or an ankle sprain as a model. That's most commonly what we see in terms of sprained joints. We think about grading ligamentous injuries. Please know that it really has nothing to do with how the injury actually looks. So you could have a patient come into the clinic with a huge ankle and they could have a grade 1 ankle sprain. You could have a patient come into your clinic complaining of ankle pain who has very small ankle, there's not a lot of effusion, and they could have a grade 3 ankle sprain. So as we talk about the grading system, please keep in mind that it really has very little to do with the way the injury actually looks and more so to do with the patient's function, their ability to have motion at the joint, and more importantly, how much instability is at the joint. So when we're thinking a grade 1 type of injury, what we're thinking is that patient has zero loss of motion in the joint. In other words, they have full range of motion, right? So zero loss of motion at the joint, or we could say full range of motion. The second thing that we know is that they'll have mild pain. So like on a scale of 1 to 10, 1 being the least amount of pain, and then 10 being the greatest amount of pain they've ever experienced. These patients typically report between a 1 and a 3 on the pain scale. And then secondarily, when we test them using special tests, what we typically will see is that this patient will report or have zero laxity or instability at the joint. So in essence, that ligament is still intact. Maybe we stretched it a little bit, but the moral of the story is that ligament is still capable of keeping that joint together. Remember what we said about ligaments. If we were to define them, they attach, remember what? Bone to bone, right? So they're going to attach a proximal bone to a distal bone. And so when we have injury to a ligament, what we typically will see is that there will be some type of joint laxity. But in a grade 1 injury, this isn't the case. So we don't have a lot of laxity. The patient will have full range of motion and they'll report some mild pain. These are the patients that we're not too concerned about, right? We'll tape them up and we'll return them to play. It's when we venture into the grade 2s and the grade 3s where we want to be more conservative in our treatment. We want to be more conservative in our decisions to return patients to play. I can't remember who it was that asked the question, but the question was, well, why are we seeing so many osteoarthritis ankles, right? And so this is where we start to see that is when we aggressively return a patient to play following a grade 2 or a grade 3 ankle sprain. So with grade 2s, these patients are going to have some loss of motion. Okay, so in other words, what we're saying is that they won't have full range of motion. Okay, they'll lack some type of motion. Most often in the ankle joint, dorsiflexion range of motion is compromised. And then also inversion range of motion is going to be compromised as well. Most often, that isn't always the case. The second thing that we see is that the patient reports moderate to severe pain. So again, if we're thinking about a pain scale, we're looking at about 4 to 7 on the pain scale. And essentially what we know is that patient also has an increase in laxity at the joint when we special test it. So I hope I'm making sense here. Last but not least is a severe or a grade 3 ligamentous injury. Most often this is going to be associated with a ligamentous rupture or just complete disruption of the ligament and its ability to hold the two bones together. So you get usually a rupture or a massive amount of laxity. So increased laxity at the joint, so much so that you have basically joint dysfunction. The pain is going to be, like a 7 to 10, right? So they typically will have zero motion at the joint. And most often that's due to the amount of pain that the patient is in. The other thing that we see when we're talking about grading systems is about how many ligaments are actually involved, or tissue structures are actually involved in the injury. In a moderate, there's just a stretching of the ligament, but no fibers are torn. In a grade 2, you have some fibers being torn, right? And then in a grade 3, like we said, you basically have rupturing or you have disruption of the majority of the ligamentous fibers holding that joint intact. So that would be the ligamentous grading scale. One thing I do want to caution you on is being sure that you're not judging an ankle or grading an ankle based on how it actually looks, but more so on its clinical presentation. When we think clinical presentation, what we're really thinking are, number 1, range of motion, number 2, pain, and then number 3, laxity. I'll put function here too, and number 3, laxity. Okay, this would be clinical presentation. Has nothing to do with how it actually looks to the human eye. Okay, on the next slide, what we'll look at are really the different types of injuries that can actually happen to the ankle joint. What we know here is these are all examples in the top row of complete ruptures. The ruptures are occurring at different portions of the actual ligament. This is what we call a mid-substance rupture. So this is mid-substance. What that means is it's right in the middle of the actual ligament. This is a proximal ligamentous rupture. You can see that the bone is still intact, so that's a good thing. Typically in this type of injury, the patient has more bony pain, and in some cases some type of like bony contusion potentially. Yeah. And then last but not least is what we call an avulsion, right? We talked about this in class. Skin can peel away, but you can also have a ligament pull away from its attachment site on a bone. And when that happens, sometimes what you'll see is the bone come with it. Most often in lateral ankle sprains, what we typically see is if the inversion mechanism is forceful enough, it will pull the ATFL, which will then pull off the most distal portion of the fibula. So this is the fibula. Okay, so you can have different types of ruptures that occur to an actual ligament. Now, as we look at A, B, and C on the bottom row, what we're really looking at is what are called partial tears. Yes, so you can see a mid-substance partial tear. Again, you can see the proximal partial tear, and then what you can start to see is a fracturing of the fibula, but it's still intact. In many of these cases, regardless of if you're looking upwards or you're looking downward, the real concern with the bottom row is preventing the top row from happening, right? So these patients on the bottom row probably are going to go into some type of walking boot to prevent that ligament from actually rupturing completely, or to prevent a bony fracture if possible. Other things to note on this slide is that if we have a total or a complete rupturing of a ligament, most often, depending on that ligament, has the ability to kind of tack down itself with healing. Typically, healing will take 6 to 8 weeks, most often, and most often they're in a walking boot. Okay, guys. So as we look at kind of these 3 different mechanisms, we can see how injury can actually happen. So let me orient you. What we have here is the tibia. So tibia is on the medial side, and then we have the fibula here, which is the lateral side. So we've got medial side and we have lateral side. Just kind of want to be clear because it tricked me at first. And then so here we have the talus, okay? And then on the bottom part we have the calcaneus. All right, so what we would say is, if we're looking at this ligament here, which happens to be the deltoid ligament, we would say this is an eversion mechanism of injury. And so what we're seeing happen is two things. Number one, the deltoid ligament gets ruptured, right? So we see that happening. But then what we also see happening is a rupture of the proximal anterior tibiofibular ligament. So this is an eversion mechanism of the ankle, an outward movement of the ankle, which causes stress to the deltoid ligament, but then also causes a high ankle sprain mechanism as well. And then if we're looking down here, what we would say is this is the fibula, and the way I know that is because it's smaller. And then this is the tibia. So again, if we're orienting ourselves, this is going to be lateral, right? And this is going to be medial. So this is an inversion mechanism of injury. And what we see is ATFL is intact, but what do we have? Like a kind of partial fracture to the distal fibula as a result of that inversion mechanism. Now, with this particular injury on the bottom left-hand side of the screen, we kind of have a little bit of inversion mechanism with rotation, right? So we're getting a little bit of rotation. The awesome thing about this is we see that all ligaments are intact. So more than likely, this is going to be a grade 1 sprain. Makes sense? Yeah. Down here, we could call this probably a grade 2. Why? Because it's not a complete rupture. And then up here, we're going to term that a grade 3, right? Because we see complete disruption of the ligamentous structure. So we have 3 different types of modes of injury. These aren't the only ones, but probably the most common that you'll see within the actual ankle joint itself. So just take a look at this x-ray. This is a finger, so we can orient ourselves. Within the finger, you have a proximal, a middle, and a distal phalangeal joint, or phalanx, sorry. And what you can see here is that you have an avulsion fractured. You see that little piece of bone kind of coming off of its actual bony place. So then again, we get an avulsion fracture. Now what we're going to do is actually talk about muscle and tendon injuries. I think it's important to kind of consider them because they do happen often in clinical practice, and they become hugely important. What you're looking at here is kind of like a muscle tendon model. In particular, remember we talked about this already, where we talked about the different types of tendinopathies, right? Where you have that synovial sheath potentially surrounding the actual the tendon, or even the fascial sheath surrounding the muscle. And so essentially what we want to always keep in mind is that every muscle and tendon is either surrounded by some type of fascia, that'd be a muscle, or some type of sheath, right? Which would be the tendon. And so as we move forward and we start to talk about these different types of injuries, this will become important part of how we describe injuries, and we describe the grading of the injury to the muscle and or tendinous structure. So let's go ahead and talk about muscle and tendon injuries. As I mentioned before, if we're talking about a strain, then essentially what we're talking about are actual muscles, right? I think that's important to keep in mind. A sprain is a ligament. A strain happens to a muscle. You can, just like with ligamentous injuries, have a mild, which is considered a grade 1. You can have a moderate injury, which is considered a grade 2. Yeah. And then you can have a severe injury, which would be considered a grade 3. Just like with ligamentous injury, the grading scale is very similar, right? So a mild injury, the patient typically will have mild pain. Yes. Typically will have full range of motion and 0 dysfunction. Yes. On a scale of 1 to 10, remember they might report a 1 to a 3. So very, very mild in terms of pain. Typically, you don't get any bleeding or discoloration, very little swelling associated with that particular injury. For a grade 2, just like with the ankle, you're going to have some actual tearing of the muscle fibers, which leads to an increase in the amount of perceived pain, which also reduces the amount of range of motion at that particular joint. And then a grade 3 typically is some type of either rupturing of the muscle belly or an avulsion fracture from its attachment site. Just depends, right? So we can see that grading scales for strains and sprains are very similar. It's just a matter of which anatomical structure is actually involved. Lastly, you've got tendinitis, which we've talked about in a previous slide, but it's as a result of most often what we see is overuse in these chronic pathologies. But tendinitis can also occur from an acute trauma. So an example would be if we take a blow to the anterior knee, and that causes, let's say, a fusion within the knee, then essentially that effusion sits there and creates a tendinopathy. So it's possible, but most commonly what we see are chronic and overuse injuries. As we mentioned in the lecture in class, an itis is truly an inflammation, right? And so just remember we have really 3 grades, right? Grade 1 is going to be tenosynovitis. Make sure I spell that right. Grade 2 is going to be tendinitis. And then last but not least, remember we said grade 3 was going to be that tendinosis. So in essence, that tenosynovitis is going to be inflammation of the synovial sheath. Yes. Tendinosis. There you are. And tendinitis is going to be actual inflammation of the tendon itself. And then last but not least, tendinosis is going to be that degradation of the actual tendon itself. Myositis, as the name implies, is what? An inflammatory condition which involves the fascia, which is the sheath that covers the actual muscle. So you get this inflammatory condition between the actual sheath and the muscle, and it can wreak havoc within the body. It can spread. It can lead to an infection, and so most often you want to get this treated as soon as is possible. In avulsion, we've talked about a lot that is a muscle or a tendon or a ligament pulling away from its either proximal or distal attachment. You've got contusion, which is a bruise, but don't use that in class. Use contusion. You've got cramps and spasms, which essentially are trigger points. We could call them trigger points, or sensitive spaces within the muscle. And then you've got delayed onset muscle soreness. So, my question to you is going to be, how many of you have worked out really hard? Let's say it's New Year's Eve, it's the New Year's resolution, right? Everybody starts working out the day after New Year's, right? So the question becomes, how many of you have experienced so much soreness that like you don't want to move the next day? That's delayed onset muscle soreness. It's this idea that you have this lactic acid buildup. So one way to kind of get rid of that, some of the research suggests, is a soft tissue massage. Other ways would be through cryotherapy, but that is delayed onset muscle soreness. So look at this image here. What we're looking at essentially is an Achilles tendon rupture. Yes, do we see that? We're looking at a partial tear of the Achilles tendon and then a repair of this Achilles tendon rupture. Achilles tendon ruptures used to take about 6 months to recover from, but we're starting to see them pushed down from about 6 months to 3 to 4 months. Just depends on the surgeon and the technique that they're using for the surgery itself. Next, we're going to keep talking about definition. So fasciitis, most often we're talking about plantar fasciitis. And what we know about the fascia itself is that it protects muscles. So it kind of lays over a muscle group. The idea is, number one, it's the kind of the tissue that's going to absorb a lot of the shock. And in a muscle's case, it's the tissue that kind of contains it. And so with plantar fasciitis, which is the most common type of fasciitis, the fascia gets inflamed. And when that happens, several things occur. A lot of pain, so patients report a lot of pain. And additionally, that swelling kind of is allowed to kind of penetrate into the actual muscle itself. So then they kind of report pain within the actual muscle, which also leads to pain with the movements involving that muscle. But in plantar fasciitis in particular, this plagues the foot. And so patients report pain on the plantar aspect of the foot. Talked about tenosynovitis, but it's inflammation of the synovium surrounding an actual tendon. Bursitis is inflammation of the bursa. There are many bursa in the body. The role of the bursa is to protect specific bony processes from friction, so to protect from friction. The most common bursa that you'll see get a bursitis is on the patella. Most often, if you think about volleyball athletes, right, who fall on their knees a lot and have a swollen anterior knee, most often that bursa has ruptured or become inflamed, and that would be bursitis. It can limit range of motion, it can limit function, certainly if it's swollen enough, most often with some type of compression device. However, it typically will resolve itself. Periostitis is important to me. What we know about medial tibial stress syndrome, or shin splints as some might call it, is number one, there are grades, right? So the first degree of medial tibial stress syndrome is really just irritation of the tibialis posterior. Second degree is what we would call periostitis, which is irritation of the periosteal lining of the bone, right? So it's the lining. And then third degree is really stress fracture, right? Which is what we see most often happen. So first we start off with this irritation to the actual muscle, which is close to the tibia. Secondarily, that that muscle is so inflamed that it starts to irritate the actual lining or tissue around the bone. And so then that essentially leads to a stress fracture in our patients. Talked about tendinosis, which is degradation or degeneration of a tendon. Most often we see that in the patellar tendon or the Achilles tendon in the foot and the ankle. We have osteochondritis, which I've kind of talked about a little bit, right? But it's this idea that you have an interruption in the blood supply to the epiphysis, and then essentially that kind of leads to like this death of, so these are arrows, so it leads to kind of a dying off of the bone, with the hope that hopefully we'll regrow new bone. Part of what we've seen in osteochondrosis is that the bone doesn't necessarily regenerate itself very well, specifically when we're in a weight-bearing bone and this is occurring. So the one that we most often think of is going to be the tibial femoral joint, or the knee joint, or the knee joint. And so when this happens, when we have something like this happening, we tend to see as the bone continues to die and that patient develops like an osteoarthritis, right? Typically, our patients are going to report knee pain relatively early on. So we'll get them an x-ray and we'll try to prevent it from progressing into osteoarthritis. So if we look here, what we're essentially seeing is plantar fasciitis of the foot, where we've got this inflammatory condition of the actual plantar fascia itself. And what we can see is that as the patient goes to toe off, it stresses that plantar fascia. And if there is an inflammatory condition, that those tissues are weaker, right? And so it leads to, or can lead to, rupturing of the actual fascia itself. There are other things that we can look for. Remember in class where I said with tenosynovitis and tendinitis, most often what you'll see on the healthy side is a thinner tendon. And then because you have so much swelling in the synovium or within the tendon itself, it thickens. So this is one way to observe a tendinopathy, is to see if in fact there is inflammation. And one way to do that is to actually look at side-by-side differences in thickness of the actual tendon itself. As I mentioned before, you can actually have inflammation of the sheath, which is tenosynovitis. So you're just seeing that here. This is the sheath that gets kind of inflamed. And then just deep to that can either be the tendon and or the muscle, which can also become compromised. So kind of what do we do for a bursitis, right? We talked about this. There's inflammation of the bursa, and I said it most often impacts the actual knee itself. What we do is what you see here. We'll kind of aspirate the knee and draw some of that fluid out. The goal is when in drawing that fluid out, the patient would increase range of motion because there isn't fluid kind of filling the joint. But as I stated before, that bursa is like this fluid filled sac. It's like a waterbed essentially. You know, you lay on a waterbed and if you jump on it, it just kind of is like a wave, right? You don't hit the bottom of the bed. Well, again, the bursa in the human body are really protective mechanisms. They prevent friction, essentially. So we can see like this superficial portion of the skin. If we didn't have a bursa there, it would create friction across the patella. And same thing here in the elbow joint, right at the apex of the elbow. You're gonna bump your elbow a lot, so we have this bursa there to kind of protect us from that. So that's bursa. We're looking at tibial periostitis, right? This idea that we're in second degree medial tibial stress syndrome, where the muscle has been inflamed and now it's kind of started to plague the actual tissue that surrounds the bone itself and protects the bone from fracturing. So as we're looking at this, what we can tend to see is like there's healing that's starting to happen around the actual tibial stress, or around the tibia, and this is a sign that we're getting ready to enter into an actual tibial stress fracture. So we want to protect our patients with medial tibial stress syndrome or shin splints, because the ultimate injury is then the development of a stress fracture, which, I mean, from previous experience, I know is really hard to resolve. So take care of the shin splints before they progress into tibial stress fractures. As I mentioned with osteochondrosis, there's this dying or necrosis of bone. And what we know about particularly the knee is that sometimes it doesn't do a good job of regenerating bone. And as I mentioned in the slide before, it really has to do with the fact that the knee bone in particular is a weight-bearing bone, and so for that reason, we tend to see a lot more osteochondrosis happening. With that said, this is an elbow joint, and the reason I know that is because I see these two little bones here, so the ulna and the radius. What we see in younger patients, in particular pitchers who throw too much, right, throw too many pitches, is that you can actually create an osteochondrosis. So you can see this little kind of gap or bone missing from the actual humerus. And so what physicians will do is kind of go in and they'll try to smooth it out. Sometimes what they'll do is actually poke bones in the hole to actually cause bleeding. And what we like about causing bleeding in a bony area is it helps bring in some of those white blood cells. It helps facilitate healing. That surgery isn't ideal because it does take a long time to recover from it. The patient spends a lot of time in a non-weight bearing position to facilitate healing. So that's osteosis. Let's talk about the synovial joint and its structure. So we're thinking about the synovial joints. We have to think about, okay, what are the components of an actual synovial joint? So the first thing that we have with the synovial joint is the actual joint capsule itself. And then what we have are the ligaments, right? So we can, if we're looking at this, and if I'm perceiving this correctly, let's just go ahead and say that this is the MCL, only because there are many fibers. So we have the actual ligament itself. We have the synovial membrane, which is kind of on the inside of the actual joint itself. There is synovial fluid. Most often that synovial fluid will sit within the actual joint. And synovial fluid is, the more and more that I teach gross anatomy, the more and more I learn is that it's like oil to an engine. In essence, it provides joint lubrication. It allows the bones to slide and glide across one another smoothly. As we get older and as synovial fluid decreases or declines, or as we encounter patients who maybe don't have enough synovial fluid, what we tend to see is the development of osteochondrosis or the development of osteoarthritis, because there isn't as smooth of an articulation between the two bones itself. The next component of a synovial joint is the articular cartilage. So what we know about bone is that it has this small, thin sheath of cartilage that kind of surrounds it. And the role of the articular cartilage is to truly protect the actual osteum or the bone itself. And when we have damage to the articular cartilage, then that can lead to actual direct damage of the bone. We have articular disc in most joint capsules in the knee, that those would serve as the kind of the menisci. The goal of the fibrocartilage is to kind of reduce joint load, to kind of dampen the shock, to absorb some of the stressors that are going to come across the joint. And then we have nerves and joint fat. So you can see that a joint, in particular a synovial joint, is a very complicated structure. When you have injury to a joint, even if it's just to the ligament, you also have injury to other structures in the actual capsule itself. So this is just another image so that you can kind of see everything in the actual structure. So you've got ligament, right, which we said was a component of the synovial capsule. You can actually see the synovial fluid in here. So imagine if we flex, right, that synovial fluid's going to kind of move and allow that bone to kind of glide off of the other bone relatively smooth. Yeah, you've got, you've got hyaline cartilage here, which is going to surround the bone and protect the actual bone from injury. Now, what we know about athletes, what we know about getting older is that as we get older, the hyaline cartilage wears down, right? And so there's less protection to the bone and more risk to what? The bone itself. So we have to be careful as we have these younger athletes participating in these jumping sports which load the joint, because the reality is what we're seeing is more damage to the articular cartilage, which essentially leads to earlier onset of osteoarthritis in our more active patients. So I hope this was helpful. Looking forward to seeing you guys in class next week. Thank you so much for listening.